Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud Sheikh, a nephrology consultant and instructor at World Kidney Academy and Glomcon Nephropathology Fellow. Today, we began a journey into the world of nephropathology, starting with one of the most practical and critical steps, which is handling the specimen. This session is a part of serial lecture series designed to bridge the gap between pathology and the clinical nephrology. Our focus will not be on overwhelming technicalities or microscopic difficulties, but rather than on aspects that truly matters for nephrologists in daily practice. By the end of this lecture, you will gain a clear understanding of how specimens should be approached, what details are most important to communicate, and how this knowledge can directly improve patient care. And rest assured, the level of details you will receive will be more than enough for a practicing nephrologist without drowning you in complexities. Think of this as nephropathology made practical, relevant, and ready to apply. And let's get started. In today's lecture, we will begin with a brief look at history of nephropathology and its milestones, followed by some pre-lecture quizzes to get us thinking. We will then move into the main fundamental pillars of diagnosis before discussing the key information every nephrologist should share with their pathologist. To ground our discussion, we will start with an opening case that highlights the essential role of renal biopsy, after which we will focus on one of the most practical aspects, how to handle the specimen properly. We will also explore the value of different stains in enhancing diagnostic accuracy. And finally, we will wrap up by revisiting the quiz questions and clarify their answers, bringing all the concepts together. The field of nephropathology has evolved through several major milestones. It began in mid-19th century with light microscopy, which laid the foundation for renal disease diagnosis. The introduction of immunofluorescence in the 1940s and electron microscopy in the 1960s revolutionized our ability to characterize glomerular disease. By the 1990s, molecular tools and refined classifications such as WHO, ISN, RPS, and Oxford, and further advanced our diagnostic accuracy, including markers like C4D in transplantation and recognition of paraprotein-related kidney disease. In the last decade, we have entered the precision pathology era using molecular diagnostics, mass spectrometry, and next-generation sequencing to identify novel disease antigens and genetic causes. Looking ahead, the future promises non-invasive biomarkers and AI-based digital pathology and personalized medicine, transforming the way we understand and manage kidney disease. To begin our session, we will start with a short set of 5 quiz questions as a warm-up activity. These questions are designed to stimulate your thinking and engage you with key concepts we will be covering today. Don't worry about getting everything right. The main purpose is to set the stage for our discussion. The correct answers will be revealed and explained at the end of lecture, so keep them in mind as we go along. Starting with the first quiz, techniques in renal pathology. Select correct statement regarding techniques used in renal pathology. Choose only one best answer. First, distractor. The tissue for immunofluorescence studies is first fixed in formalin, then frozen and serially sectioned. Second choice, electron microscopy tissue is fixed in glyceraldehyde, which is an excellent tissue fixative and therefore preferred for ultrastructure evaluation. Third choice, the best approach to first evaluate the light microscopy and based on finding decide if whether immunofluorescence and or EM studies are needed. Last choice, special stains such as PS, silver, or trichrome stains are of limited use in the kidney pathology. Second quiz, we have immunofluorescence staining patterns. Select the best answer regarding staining patterns showing in image A and B and C. A, interstitial staining in A, then capillary wall staining in B, then non-specific staining in C. Or A, mesangial staining, B, capillary wall staining, C, non-specific staining. Or A, mesangial staining, B. Granular capillary wall staining, C. Linear capillary wall staining, or last one, non-specific staining, B. Granular capillary wall staining, C. Linear capillary wall staining. Moving to the third question, select the best answer regarding EM. Choose only best answer. A. Electron microscopy provides a higher magnification and resolution when compared to light microscopy. B. Electron microscopy provides ultrastructural details that are often essential for correct final diagnosis. C. Electron microscopy utilizes expensive equipment and maintenance at cost often prohibitive for investment. D. Electron microscopy samples are ideally fixed in glutaraldehyde, but samples can be retrieved from a paraffin block. E. All of the above. Then select the best answer regarding the immunofluorescence technique. Immunofluorescence can be performed on fresh frozen tissue or on paraffin-embedded tissue after antigen retrieval. B. The processing takes days to complete. C. Typically fresh frozen tissue is sectioned and the same section is stained with the entire panel of antibodies that include heavy and light immunoglobulin chain complement components, albumin and fibrin. Select the best answer regarding images A and B and C. A. This stains in A. Congo red, B. PS, C. Trichrome, or A. H and E, B. Pass stain, C. Trichrome, or C. A. H and E, B. Jones silver, or C. Trichrome, D. A. H and E, B. Silver stain, and C. Toluidine blue. Which one is correct? As we progress with our knowledge, we realize that this is not sufficient and we need to have more things, including molecular diagnostics, genetics, and also other techniques. But so far, we are most dealing with these techniques, and we will try to go over the basics of these techniques. They're essential for our work. We should use clinical data like history, examination, and investigation, light microscopy, the early snapshot of the process and what's happening, and immunofluorescence, immunohistochemistry, adding and revealing, and sometimes diagnostic. And the last is EM, the maximum ability to diagnose, and it was in its place will be very confirmatory for some disease. And the most important is the integration of all of that. Before we start, keep in mind that a kidney biopsy is just a snapshot in time, shows exactly what's happening at that specific moment. Delaying or postponing it in not proper time, it means missing that window. And remember, it's not a time machine. For kidney pathology, communication between the nephrologist and pathologist is not optional, it's essential. The information you provide gives context to the biopsy. Without this information, the pathologist is essentially working in the dark. For example, knowing the duration of the disease, whether acute, such as a few days of rapidly progressive renal failure, or chronic, such as years of proteinuria, immediately influence how the tissue is interpreted. Similarly, clear medical history can guide the pathologist, like diabetes may suggest diabetic nephropathy, lupus raises suspicion of lupus nephritis, while positive family history might indicate inherited conditions such as Alport syndrome. Details of systemic illness like infections, vasculitis, or malignancy also shape the differential. Beyond history, clinical and lab data are equally important. The renal profile distinguishes acute from chronic kidney injury. Urine analysis showing red cell casts suggests GN, while abundant white cell mites indicate interstitial nephritis or pyelonephritis. Protein quantification helps also the pathologist to decide if the process is nephrotic or nephritic. Serology titers such as AME, ANCA, and anti-GBM antibodies directly connect these specific diagnostics. Even a simple note about medications received like nonsteroidals, antibiotics, or chemotherapy can completely change the interpretation, as many drugs as well known to cause kidney injury. In short, the more complete the communication, the more accurate and clinically relevant the pathology report becomes. The decision to order a kidney biopsy is not always straightforward. In some cases, the indication is very clear and sharp, for example, unexplained acute kidney injury, nephrotic syndrome, or suspected systemic disease involving the kidney. On the other hand, biopsies may sometimes be falsely cancelled under the assumption that they are unnecessary, leading to missed opportunities for early and accurate diagnosis. Between these extremes lies a large gray area where the decision is less certain and requires careful clinical judgment. In such situations, the nephrologist must weigh the potential benefits of obtaining a precise histological diagnosis against the risk of the procedure, always considering how the results will impact patient management. The balance highlights the importance of collaboration and experienced clinical context in guiding biopsy decisions. Renal biopsy play a pivotal role in guiding management. Clinical features and lab markers can suggest their diagnosis, but only histopathology can accurately classify the type and severity of lupus nephritis as defined by ISN and RPS classification. The biopsy distinguishes between proliferative forms that mandate aggressive immunosuppression and non-proliferative lesions that may be managed more conservatively. It also provides crucial information on chronicity, activity indices, and the degree of irreversible damage, which directly influences prognosis and therapeutic intensity. In many patients, biopsy findings change the initial management plan, sometimes escalating treatment with cytotoxic agents, and the other times avoiding unnecessary exposure to potent immunosuppression. Thus, renal biopsy not only confirms the diagnosis but also personalized therapy, balancing the disease control and safety. Let's take this case, for example. We have a 40-year-old female with a history of systemic lupus erythematosus. Clinical data revealed serum creatinine 9.6. Previously, it was 1.8. C4 is low, C3 is borderline, proteinuria 2.1 gram. Previous biopsy 8 months ago revealed class 4 lupus with segmental proliferative lesions, 30% global glomerulosclerosis, and 20% interstitial fibrosis. The question is, what information could the biopsy provide to in such biopsy interpretation? The biopsy will reveal some important data like classification assessment, severity assessment, and critical finding, what is going on with the patient, then additional investigation to reach diagnosis, starting with classification assessment. This is active lupus or not? Is there any class shift? Which class is it? Confirmation or prognosis or progression like class 3 to 4 or mixed class 5 with class 3 or 4. Severity assessment, activity and chronicity indices, presence of crescent, cellular or fibrous, what's the percentage of activity versus chronicity? Do we treat aggressively this patient? Do we need that? And critical finding, why is this creatinine so high from 1.8 to 9.6? Is there any vascular lesions, TMA, lupus vasculopathy, or antiphospholipid overlap? Is there any highline thrombi or onion scan lesions which indicate severe vascular involvement? Additional investigation, EM, presence and location of deposits, subendothelial, subepithelial, mesangial, will help to classify mixed forms. And degree of interstitial inflammation. Is there any neutrophilic infiltrates may suggest secondary infection versus active lupus inflammation? Is there any superimposed pathologies like infection-related GN, drug-induced interstitial nephritis? So biopsy interpretation indicates severity and guides aggressiveness of therapy, and these findings will make a difference. The first step in sampling process is to ensure that adequate core has been obtained, which should be checked as a bedside before sending it to pathology lab. Today, several methods are available to verify this, such as dissecting microscopy, which is providing optimal visualization of glomeruli at bedside, and also magnifying hand lens, which will give you less visualization compared to microscopy, but more accessible. And also we have now mobile apps, applications. Magnification provide portable alternative. And this study, this prospective cohort study from Indian Journal of Nephrology evaluated the use of smartphones camera with macro lens to assess kidney biopsy adequacy at the bedside. Among the 34 patients, 32 native and 2 allografts, 47 samples, the average core length was 1.5 to 2 centimeter, and the glomeruli could be identified in all specimens using smartphone method. Compared to light microscopy, there was substantial agreement with positive agreement of 91.4% and negative agreement of 23.1%. The study concludes that smartphones are practical, low-cost tool to reliably evaluate biopsy adequacy and at the bedside before formal pathology assessment. Make sure to inform your pathologist as the communication ensures optimal sample detection. If medulla detected, proceed with obtaining another core to ensure adequate cortical tissue. And we should know that bedside examination with magnifying tools can decrease the rate of failed biopsies by 50% according to studies by identifying medullary tissue early and allowing for additional core samples. We should know also the gross difference between medullary tissue and cortical tissue. This medulla lacks typical glomerular dots appearance, appears more homogeneous and striated, inadequate for most diagnostic purposes. When predominant, you should proceed with another core and ask the radiologist to obtain this core. We should know also that medullary will be diagnostic in some circumstances, will be mentioned later in the lecture. For the cortical tissue, this contains glomeruli, this one on the right, that appears as reddish, circular, and rounded structures. Dotted appearance under magnification. This is ideal for diagnostic evaluation. And this is the target tissue for most renal diagnostics. We should know also that renal biopsy is an invasive procedure that requires proper technique to ensure adequate tissue sampling and minimize complications. We require 2 or 3 long course for comprehensive assessment. Needle size, we have two common needle gauges, 16 and 18, but we should use 16 according to the guidelines because there is optimal balance between tissue yield and safety in this size. Benefits of 16 according to studies: less complications with appropriate needle size, less repeated biopsies due to adequate sampling, more glomeruli obtained for assessment, more adequate tissue for diagnostics. Important reminders that request from your pathologist to follow these guidelines from your radiologist, not pathologist, when he is taking the sample. And you should know that automatic biopsy devices may yield up 50% medulla, and you should be aware of this point. For a native kidney biopsy, adequacy generally requires at least 10 glomeruli, ideally 20, at the least 1 or 2 arteries to assess vascular pathology. While for renal allograft biopsy, the Banff criteria defines adequacy as more than or equal to 7 to 10 glomeruli plus at least 1 artery. Samples with 5 to 6 glomeruli or no artery are considered minimal but interpretable, and those with less than 5 glomeruli with no artery are inadequate. For the counting method, we count glomeruli in the largest serial section, and general consideration to be in mind. For diffuse, for focal disease, large number of glomeruli needed, maybe 20, like FSGS, not to be missed any lesion. And for diffuse disease, smaller number of glomes are be sufficient, like in IgA nephropathy and membranous. Minimum for immunofluorescence and immunohistochemistry for diffuse disease, even one intact glomerulus may be enough for diagnosis, but as we will know later, it's only diagnosis, but we will miss many prognostic factors like activity and chronicity. Keep in mind that interpreting renal biopsy requires a special consideration, particularly when distinguishing between focal and diffuse lesions, as the accuracy depends greatly on quality and representativeness of the core and sample obtained. For example, focal. The more the percentage of focal lesions, like in FSGS, the less to miss the diagnosis. If you have only 10 gloms, you would have percentage of FSGS not represented in the biopsy. And you keep in mind that no cutoff of gloms and no cutoff number of gloms to exclude focal lesions, but at least 20 gloms need to exclude FSGS. For diffuse lesions, examples like membranous, IgA, amyloidosis, and post-infectious, single glom could be enough for diagnosis. However, 3 to 4 glomeruli would be more revealing for complete assessment. But again, you have no information about prognostic factors, grading activity, or staging chronicity. You cannot assess the degree of EFTA, presence, or necrosis or sclerosis. So our rule here is the more glomeruli in a core, the more diagnostic acuity you will gain. For more clarification of the previous concept, a small sample size can lead to misleading quantification percentage. Like for activity, if we have just 5 gloms and 1%, it doesn't mean that we have 20% presentic pattern. Also for chronicity, if you have 1 global sclerosis in sample of 6 gloms, it doesn't mean that we have low rate of global sclerosis. And the number of gloms in the biopsy gives the clinician an idea about how accurate the pathology report is. The location of biopsy core is always important. For instance, if the sample is taken from subcapsular tissue, it will predominantly show sclerosis and chronic changes, which may exaggerate the degree of damage and not truly represent the rest of the cortical parenchyma. Similarly, in early FSH often begin in juxtamedullary region. So if the biopsy is not sufficient deep from this side, these early lesions may be missed. So what is the best site to take? Cortex plus or minus capsule is the best site to obtain your core. Does size of the core matter? Yes, good long core for better evaluation is needed, not less than 0.8 length. Small samples, even with good number of glomeruli, could miss inflammatory and degree of EFTA, because most of renal disease are patchy in nature. This is a good long sample core, and this is a small core even if we have many gloms represented here. Moving to handling the specimen fixation, important handling guidelines: specimen should be fixed, but also avoid overfixation, which will be explained later. Why fixation? Because it undergoes tissue autolysis if left unprocessed. So don't send the specimen only in saline. This is not effective. No one fits all modalities. In light microscopy, we are using 10% neutral buffered formalin, and should be this formula. If you have no phosphate for buffering, you can use salt tablets, but at least it should be neutral, 10%. For immunofluorescence, you should obtain fresh tissue, snap frozen or transport in Mitchell's media to pathology in only 10 minutes. For electron microscopy, 4% glutaraldehyde used as effective, and we will talk about this issue later in details. For immunohistochemistry, same core sent for light microscopy, which is 10% neutral buffered formalin. Mitchell's media is not actually effective. It's buffered saline, contains some protease inhibitors, prevent immune complex from falling apart, but doesn't prevent autolysis, so the tissue cannot stay there for a long time. Glutaraldehyde is much better effective than formalin. Formalin could be great for general pathology, bigger pieces of tissue. For light microscopy, it's great effective, but when it comes to ultrastructure, glutaraldehyde will be the best. One thing regarding glutaraldehyde is that it's a big molecule, doesn't penetrate tissues. So if you put large tissue in a small bottle, you will end up to autolysis in the middle of it. Only outside will be fixed. But anyway, we are not need a big piece. 1 or 2 millimeter for renal cortex that contains 2 glomeruli will be enough for EM. In terms of division and preparation, at least 2 cores are required. For EM, only a very small amount of tissue is needed, about 1 millimeter from both ends of the two cores. If immunofluorescence is planned, allocate 2/3 of one core and 1/3 of the other core, like this, 2/3 from here and 1/3 from here, leaving the remaining tissue for light microscopy. If for immunofluorescence, if immunohistochemistry is required, there is no need to further divide the cores after sampling for EM. The remaining tissue can be used for both light microscopy and immunohistochemistry. Finally, remember that saline is used only to keep the core moist, wet, not as a fixative. The importance of obtaining good biopsy core cannot be overstated, as certain diseases require specific diagnostic approaches. For example, an Alport syndrome immunohistochemistry is not necessary for diagnosis, while in conditions such as IgA nephropathy, light microscopy and immunohistochemistry alone are often sufficient. Moreover, securing an adequate core can be particularly challenging in situations such as patients with solitary kidney, obesity, or poor compliance. In such cases, even single well-obtained core becomes extremely valuable. Another important consideration is how the tissue is handled in terms of freezing and cooling. For specimen fixed in glutaraldehyde, freezing is not required. Instead, they should be placed in ice bags cooled to a degree of 4 to 6 Celsius, but not stored in refrigerator. In contrast, formalin fixed specimen shouldn't be cooled, as fixation is a heat-dependent process, and lowering the temperature can lead to significant artifacts. Don't mess labeling of the specimen with the name and nature of the specimen. Is it native or graft, and test required for fixative. For light microscopy, samples is first wrapped in tissue paper, then placed in a tissue bag, then inserted into cassette. From there, it's processed and embedded in paraffin and sectioned at cutting station. At this station, sections are mounted on slides, and serial sections are prepared, and various stains can be then applied at this station. Proper embedding is absolutely critical. If done incorrectly, up to 50% of the core may be lost during processing. Additionally, paraffin block is often stored and may be needed years later for further evaluation or additional studies, so it's very important. Also, you should keep in mind this embedding in a proper way. Embedding like this is the correct way, and this will maybe 50% of tissue will be lost. Maybe you're not representative in the slides. Moving to another important aspect, cutting and sectioning. Keep in mind that sections must be cut at specific level and thickness, as this directly affects the accuracy of morphological interpretation. If sections are too thick, like here, they may create misleading appearance and obscure details. If too thin, important features can be lost. So the ideal thickness is 2 to 3 micrometer. Thin sections are at this range are essential for optimal visualization and cellular details structural component. After sectioning, the slides should be numbered sequentially to allow proper tracking of any suspected finding, especially given the focal nature of certain lesions. This allows facilities applying different stains to consecutive sections. For example, an early crescent observed in one section may be followed in the next serial section, like here. This is the start of crescent followed in the serial section to a whole full crescent. So this appear as fully developed crescent to assure the finding what is this artifact or another pathology or not. Again, serial sections allow pathologists to track findings and diagnose focal lesions across different levels of tissues using various stains to highlight different structures. And this is stains applied H&E, PAS, and silver, trichrome applied to serial sections. And this is the position of each section. Name this. Each one of this is serial section. Again, we will numbered 1, 2, 2, 3 to follow any developing lesions. There are a variety of stains used in renal pathology, including routine standard stains and additional special stains. The basic panel typically includes H&E, PAS, silver, trichrome stains. Additional stains used for specific purpose may include congruent, COSA, and elastic stains, and others. The choice of stains often depend on the center's protocols and sometimes on pathologist preference and experience. Detailed information about each stain will be discussed in the following slides. Starting with H&E stain is the most commonly used stain in general pathology labs. H&E provides an overview of the overall patterns of injury. For example, mesangial-proliferative patterns may suggest IgE nephropathy or class II lupus nephritis, while MB membranoproliferative membranous or nodular patterns help narrow the differential diagnosis. In addition to general morphology, H&E allows assessment of cortex versus medulla, glomerular count, inflammatory cell infiltration, interstitial edema, and tubular damage. However, for kidney-specific pathology, pathologists often prefer PAS stain as it highlights structure and patterns more effectively. Moving to silver stain, which is less commonly preferred by pathologists due to technical difficulty needed for expert processing and higher cost. But at least one slide is usually performed. Silver stain highlights the base membrane in black, aiding to visualization of changes such as spikes in membranous nephropathy. It also contains mesangium will stain it in black, allowing assessment of mesangial expansion or other pathological alteration. And this is the picture of spikes in membranous nephropathy. Next, we have the most commonly used kidney-specific stain, PAS stain, which stains the base membrane in purple. It's often considered cost-effective alternative to silver stain, and they call it the poor man alternative to silver stain. PAS stain allows detection of capillary wall collapse, glomerular base membrane changes or tubular thickening, base membrane of tubules, and helps to identify hyalinosis, mesangial hypercellularity, or expansion, and if there is any mesangiosis or something. Moving to trichrome stains, which are used to differentiate collagen and fibrous tissue from other tissue types and are particularly valuable for detecting interstitial fibrosis. There are two main types of trichrome stains: Mason trichrome, which stains fibrous tissue in green, and chromophobe aniline blue, which stains in blue. Trichrome is also very effective for assessing fibrinoid necrosis in arteries and interstitial edema. Early fibrosis typically appears green. Why it's called trichrome? Because it's stained with three colors: nuclei in black, glomerular immune deposits in red, and epithelial changes in purple, allowing visualization of multiple tissue components in a single slide. Next, we have Congo red stain, which is essential for diagnosis of amyloidosis. Some centers consider it routine stain, particularly in patients over 50 years of age. For optimal evaluation, the section should be thickened up to 5 micrometer. The slide is examined under polarized light, which reveals the characteristic apple green shape in this slide of amyloid deposits. Simply observing orange color is not diagnostic because collagen also stain orange with congruent, which can lead to potential false positive result. So this color under light polarized light is diagnostic, and this without polarized light is not diagnostic, only green, and this is apple green by Fergusson's diagnostic shape. Moving to immunostaining, which is essential for diagnostics in certain diseases such as IgA nephropathy, C3 glomerulopathy, and light chain deposition disease. There are two main types: immunofluorescence, which stains the green fluorescence color against dark background, and immunoperoxidase, which produce brown staining. Different antibodies are used depending on the diagnostics needs, including IgA, IgG, IgM, C3, C4, C1q, kappa lambda, and IgA subclasses, anti-specific antibodies such as C4d in renal transplantation, and anti-PLAR in membranous nephropathy, and CMV or polyomavirus markers in post-transplant viral infections. The tissue must first be frozen and then sectioned in cryostat. This is the cryostat. Once frozen, it's cut with a special knife and sections are collected on a warm slide. As the tissue touches the warm slide, it adheres, allowing visualization and application of the appropriate stain, which this is a N shape before staining. And this slide compares immunofluorescence and immunoperoxidase techniques. Immunofluorescence frozen sections required, whereas immunohistochemistry can be performed in formalin fixed tissues. It doesn't provide permanent sections in immunofluorescence. Samples are typically usable for only about 2 weeks before they must be discarded. In contrast, immunohistochemistry allows for permanent sections that can be used for 3 to 4 years. Immunofluorescence is highly sensitive, simple, and fast. Although newer immunohistochemistry techniques have become faster and easier, they still have moderate sensitivity because they contain formalin coagulase proteins, which will affect the sample. Historically, immunohistochemistry detected limited range of antigens, but modern methods have narrowed the gap. Sensitivity is now comparable to immunofluorescence. Even certain antigens, such as anti-PLR2 for membranes, are designed mostly for immunohistochemistry, not for immunofluorescence. Next, we assess the quality of the staining, including the intensity, pattern, and specific structure stains, such as mesenchyme or capillary walls. For example, in negative glomerular stain, you wouldn't see significant staining like here, but the glomerulus and around tissue will be still visible. Occasionally, the area of collagen in the mesenchyme may show ultra reflection, which can be misleading. However, a higher magnification becomes clear, and there are no true granular deposits, but rather normal tissue artifacts. We have two main patterns, linear and granular pattern. Linear is a continuous ribbon-like staining, is diagnostic for anti-GBM disease along glomerular-based membrane. Not only this for immunofluorescence, not visible for immunoperoxidase, and the granular pattern is discrete dots like deposits, like here, diagnostic for immunocomplexities like lupus, IgA nephropathy, in mesenchyme, subepithelial, subendothelial, according to location. Node can be identified in both immunofluorescence and immunoperoxidase in some power magnification. This is a picture of immunohistochemistry revealing the granular pattern, so we can use immunohistochemistry and immunofluorescence for this pattern. But again, we cannot use the immunofluorescence for linear immunohistochemistry for linear pattern. It is immunofluorescence based morphology. So for suspected NGBM disease, immunofluorescence remains the gold standard for diagnostic technique. Moving on electron microscopy, there are two types: scanning EM, this one, and transmission EM, this one. In clinical practice, we routinely use only transmission EM. Scanning EM provides detailed surface image such as podocytes covering the glomerular tuft, but it's not useful for diagnostics. In transmission EM, electron pass from this part, from the top. The slide is positioned in the middle here, and the image is viewed from the bottom, similar to optical microscopy, but images are usually viewed digitally on monitor screen like this. EM is an expensive technique and is not widely available in many countries with cost-effective strategies like most of European countries. It's typically available only in large institutes and large hospitals. Transmission EM allows visualization of ultrastructural changes, including electron-dense deposits, glomerular-based membrane thickness, and any alteration in it, amyloid fibril thickness, podocyte effacement, and endothelial cell swelling. The processing of EM sections is slightly different from routine processing. The tissue is first cut into 1 millimeter cubes and embedded in resins. Semi-thin sections are first examined under light microscopy with this toluidine blue for semi-thin sections. to locate focal lesions, and then one or two glomeruli are selected for EM analysis. This is why large cores are not necessary for EM. The characteristic black and white appearance achieved using uranyl acetate and lead citrate stains. EM blocks this one, made of extremely hard plastic, unlike paraffin, because higher energy of electrons requires much strong medium. This epoxy blocks contains the tissue samples, which appear as black dots within the epoxy blocks. Um, And we should know that the electron microscopy is essential for diagnosis in certain body cytopes such as minimal change disease and FSGS, and hereditary disease like Fabry, Alport, and thin membrane disease, as well as deposition disease like immunotactoid glomerulopathy. It's also confirmatory in conditions including immune deposition disease like endothelial cell swelling, viral infections, and crystalline nephropathies. However, EM has some limitations. It can be misfocal lesions, also cannot reveal the exact nature of any deposits. It's also useful in disease that not useful in disease that lacks specific ultrastructures changes. Going to our quiz answers, and the answer for this question was B. Electron microscopy tissue inspection glutaraldehyde, which is an excellent tissue fixative and therefore preferred for ultrastructural evaluation. Other we're talking about the glutaraldehyde. We should know that it's just too toxic and penetrate tissue slowly, so formalin is preferred for routine tissue fixation for light microscopy. Tissue for immunofluorescence studies is not fixed, can be immediately frozen and sectioned or placed in Zeus or Mitchell's medium for better preservation if it can't be frozen right away. All kidney biopsies should be studied by light immunofluorescence and electron, but this is often not the case due to high costs. In most labs, PS, silver, and trichromatin are done routinely, and they are extremely helpful for evaluation of kidney parenchyma. And the answer for this quiz, this is the mesangial staining pattern, and this granular capillary wall staining pattern, and this the linear capillary wall staining. Immunofluorescence images, apart from the intensity, it's more important to evaluate the location also. Mesangial versus capillary wall staining. The quality of staining, such as granular versus linear staining, provide crucial diagnostic information, as we mentioned, maybe membranous versus HPM. Based on different location and texture or quality of staining, one can come up with differential diagnosis. Pattern recognition in immunofluorescence is essential for accurate diagnosis of various glomerular diseases, including lupus, IgA, and membranous, as we mentioned previously. Going to this quiz, the answer was all of the above. The ultrastructure details that this technique can provide very helpful and often essential for correct final diagnosis. EM utilizes expensive equipment and maintenance that's often prohibitive of investment, very expensive. EM samples are ideally fixed in glutaraldehyde, and this is sort of fixative that penetrates the tissue slowly but provides excellent fixation and ultrastructural detail. When needed, samples can be retrieved from a paraffin block. This is a great rescue technique, very good one. The traditional high voltage EM techniques is still providing better quality of final images than low voltage EM, which requires slightly lower initial cost and less space for the equipment. The sample preparation is the same for both techniques. Rapid EM processing can save time but often results in artifacts. Going to this quiz, the answer was immunofluorescence can be performed on fresh frozen tissue or in paraffin embedded tissue after antigen retrieval. IF technique, immunofluorescence technique, is ideally performed on fresh frozen tissue but can be performed on paraffin embedded tissue after antigen retrieval, which is called pronase digestion. Fresh tissue can be frozen immediately or can be placed in tissue transport medias like Zeus Mitchell's for several days and then washed in PBS prior to freezing. The frozen block is serially sectioned to provide a set of slides that can be stained with a panel of stained This panel may be variable in different labs, but ideally should include heavy immunoglobulin change and light changes like kappa and lambda, complement components C3, C1q for transplant, C4d, and in some labs C4, albumin and fibrinogen also stains. The processing usually take about a couple of hours to complete for routine direct immunofluorescence or slightly longer for some stains requiring secondary antibody. Going to the last quiz, and the answer was A, H&E stain, and B is silver stain, and C, trichrome stain. In general, H&E stain most commonly used in stain in pathology, but most kidney pathologists prefer PS stain for proper visualization more than H&E. H&E will point out similarity, while PS stain is great for architecture because it stains base membrane. Silver stain, similar to PAS, it also stains collagen and great for evaluation of the architecture and base membrane changes such as spikes, double contours. Trichrome stain stains collagen blue, and we use it for evaluation of interstitial fibrosis. Congruent stain used routinely in some labs for detection of amyloid. The stain should always be polarized to look for apple green picture. Toluidine blue used in renal pathology typically for thick, semi-thin sections of EM. Quick stain that's great for epoxy sections and to reveal the histology of the sample submitted for EM. And thank you so much for listening, and see you inshallah in the next pathology lecture inshallah. Thank you.